of the Asian Pacific Society of Cardiology in collaboration with the Asia Pacific Cardiometabolic Consortium. And what we'd like to do over the next hour is focus on two of the key results that were presented at last week's annual scientific meeting of the American College of Cardiology. I'm joined today by my colleagues, Associate Professor KK Yeo from National Heart Centre in Singapore, Dr. Adam Nelson from Monash Heart in Melbourne, and Professor Jian-Jun Li from the Wuwai Hospital in Beijing. And we're going to focus predominantly on the ongoing saga, one might say, of omega-3 fatty acids and cardiovascular disease, then move on to looking at perhaps a novel way of trying to perform a cardiovascular clinical trial, and then kind of talk about that and some other aspects of what we saw last week. So on that note, I'll get the ball rolling and I'll hand over to KK, and he is going to talk about the relationship between omega-3 fatty acid levels and MACE in patients with high cardiovascular risk. Thanks, KK.
Thanks, Steve. ACC had a bunch of interesting studies, and one I'm going to share with everyone is the strength subgroup, or rather sub-study. And this is a review of what was presented there. And I should mention that Steve himself is a principal investigator of the strength study. So it's interesting that I'm presenting this here. And as you can imagine, most of the slides are from him. So these are some of my disclosures. So this is the trial, that's the sub-study or secondary analysis as presented by Professor Steve Nissen at ACC. And I think as background, we do know that population studies have shown that greater consumption of fish and fish oils are associated with cardiovascular protection. The earlier studies from GC suggested that the omega-3 fatty acids are protective, but there are also lots of studies which show that low-dose omega-3 fatty acids have no benefit, and this includes Origin, Ascend, Vital, etc. So it was interesting that about was it 10 years ago that the Japanese Gelis study showed that in this cohort of almost 19,000 Japanese patients, the combined use of EPA, omega-3 fatty acids with statins appeared to have effective reduction in cumulative incidence of major coronary events to the tune of about 19%. And this was with a triglyceride reduction of 5%. More recently, in 2019, the REDUCE-IT trial was presented and published in the New England Journal of Medicine. And you can see from these summary slides that the primary composite endpoint of cardiovascular death, non-fatal MI, non-fatal stroke, unstable angina, and a repeat revascularization appeared to have a significant benefit of 25% reduction in the event rate. And this was, of course, associated with a reduction in triglyceride as well of about 19%. Last year at the American Heart Association meeting and published as well in JAMA by Steve and his colleagues from the strength trial investigators. The strength trial showed that, perhaps just a quick summary of the strength trial. The strength trial compared omega-3 carboxylic acid with corn oil placebo. And this carboxylic acid formulation was chosen because it was felt to be able to achieve higher and more reliable blood levels of the omega-3 fatty acids. It was also, corn oil was chosen as a placebo because mainly because it was felt that the other types of oils, such as olive oil, was likely a positive control and mineral oil a negative control. And this study, the strength trial, enrolled patients at high cardiovascular risk with elevated triglycerides. And the primary endpoint was similar to that of the REDUCE-IT study. The strength trial had 13,000 patients. And I just want to say that the tracking of outcomes, the vital status was attained in almost 100% of patients and MACE outcomes in 96.6% of patients. The study was closed early for futility in earlier than initially planned for futility reasons. I just want to highlight a few key points within the strength trial that segue to the subgroup analysis. First, the triglyceride reduction was similar to the REDUCE-IT study with about 19% reduction in triglyceride levels. Not much change in terms of the other lipid parameters. Interestingly, there was a reduction of about 20% in the high sensitivity CRP in the omega-3 carboxylic acid group. Similarly, this was associated with a rise in the plasma EPA of about 268% and a rise in the plasma DHA of about close to 40%. In the corn oil group, as you can see, there was no such increase, and in some instances, and there was in fact a decrease. The primary endpoint in the main strength study showed that there was no difference. The lines were almost identical across the omega-3 carboxylic acid group and the corn oil group, and this was borne out in the various primary endpoint components as well as all-cause mortality. So in this particular secondary analysis that was presented at ACC, which has been published in JAMA Cardiology, the following questions were asked. Again, to use the REDUCE-IT study as a key reason why these questions were asked, we remind ourselves that the REDUCE-IT showed a hazard ratio of 0.75, statistically significant, while strength did not show any difference at all. Three hypotheses were generated to explain why there were differences. The first hypothesis is that mineral oil used as a placebo in REDUCE-IT increased the LDL by 10% or close to 11%, and the highest sensitivity CRP by more than 30%, raising concerns whether the favorable results of the omega-3 in REDUCE-IT was driven largely by mineral oil toxicity. Strength used corn oil, which exhibited neutral effects. The second hypothesis was that REDUCE-IT used purified EPA to achieve moderately higher EPA levels compared to strength. Could the higher EPA levels explain the more favorable outcomes in REDUCE-IT? In the strength study, there was a mixture of EPA and DHA. Could the DHA component have exactly counterbalanced the benefits of EPA, resulting in a precisely neutral outcome in strength? And so this particular sub-study was meant to examine the second and third hypothesis. And these are some of this, we have already discussed this a little bit earlier on, just to highlight that the EPA and DHA levels were available in about 10,300 patients out of the 13,000 patients, and these levels were available both at baseline at 12 months. The primary outcome measure for this sub-study was the hazard ratio for the top tertile of achieved EPA and DHA levels in the omega-3 carboxylic acid group compared to the corn oil reference group. So these are some of the baseline characteristics. There are really no differences between the various tertiles of the omega-3 or the achieved EPA levels. Again, in terms of the various cholesterol subgroups, not much difference across the three tertiles. And now this is, of course, interesting in of itself, because you notice that across the tertiles of EPA, I just want to highlight that the triglyceride levels appear to be somewhat similar across tertile 1 and tertile 3, which I think also makes for interesting discussion later on. Now, in terms of the EPA and DHA levels, you will see here the plasma EPA as well as red blood cell EPA levels, the RBC EPA levels, and you can see that there is across the tertiles there is definitely an increase, which is as expected. And in terms of the cardiovascular outcomes, according to achieved EPA levels by tertiles, there really is no difference. And again, if you look at the DHA levels across the tertiles, no difference across the tertiles for cardiovascular outcomes. The next series of slides, as presented, show plasma EPA and plasma DHA levels compared to corn oil. Again, no statistically significant difference. If you look at change in the plasma levels of these two, of EPA and DHA, again, no statistically significant difference. If you look at RBC EPA or DHA, no difference. If you look at RBC EPA in terms of change, or DHA in terms of change, no difference. There is some correlation between EPA and DHA levels with a modest correlation as shown, which of course brings to mind whether or not the tracking of these two subcomponents of omega-3 could have indeed created some sort of balance. But as you saw from the earlier slides, the levels of change in EPA was much higher than that of DHA. So there were some limitations in this particular subgroup analysis, and because it's a post-hoc analysis, they remain hypothesis generating, and the statistical power in having only a third of the population for this study, of course, means that there's reduced statistical power. And I've already mentioned the moderate correlation between EPA and DHA. So the conclusion of this particular sub-study as presented at ACC was that despite a 443% increase in EPA levels with omega-3 carboxylic acid, the top tertile was not associated with any benefit. And despite a 68% increase, the top tertile of DHA levels was not associated with harm. And these findings in the context of the increased risk of atrial fibrillation in the omega-3 trials both reduce it and strength. There was uncertainty as to whether there is any net benefit or harm with omega-3 preparations. And the researchers concluded that further research will be required to potentially compare corn oil with mineral oil and to compare the various forms of omega-3 fatty acid formulations. Well, I'm just going to share some thoughts before we launch the discussion that Steve will lead. Well, first is that, I mean, as I read the papers, I couldn't help but notice that Reduce It was a joint academic sponsor with the sponsor in the steering committee, and the sponsor collected, managed, and analyzed the data. Strength had the independent academic steering committee, and the Cleveland Clinic trial group did the analysis. We have really talked about mineral oil versus corn oil. And I think that it's still entirely, not entirely, but there's still the possibility that the EHA and DHA cancel each other out, although given the numbers and the quantity of changes, it's less likely. And I still don't understand why the TG was not associated with the plasma EPA levels according to tertiles. We have talked about the rise in the LDL cholesterol as well as HSCRP in Reduce It, and that I think suggests that there is potentially some toxicity with mineral oil. And I think in the context of the APSC and the APCMC, it's interesting that in the strength study, there is a signal in the Asian patients that appear to have some benefits, but this is only about, I think, in 600 patients or so. Sorry, 2,000 over person years, but about 600 patients or so. Similarly, in the Reduce It subgroup analysis, but in a very, very small cohort, there appears to be some benefit as well, although this is in 130 patients in each arm only. So I think with that and the concerns about atrial fibrillation, I would like to maybe hand it over to Steve to lead the discussion. Thank you.
Thanks, KK. Great overview. Maybe Professor Lee, I might start with you. You know, we see a lot of studies in the omega-3 fatty acid space. We saw the JELIS study from Japan show kind of benefit with open label administration of EPA, and then we saw benefit would Reduce It, and then no benefit with strength. Where does this all leave us thinking about omega-3 fatty acids from a cardiovascular perspective?
I would like to show my slides for your presentation.
Thank you.
And I guess while Dr. Lee is bringing up his slides, I wonder whether Steve, as one of the PIs, as the PI in strength, were you surprised to see the signal from Asia?
I think we're always a little bit cautious with trying to interpret too much from subgroup analyses because they don't reflect the randomization that the study overall did. That being said, we clearly see an interesting signal there. It wouldn't necessarily surprise me that the use of omega-3s are very different in different parts of the world. Consumption of fish is different in different parts of the world, and tells me that maybe that would be an interesting kind of question to explore. You know, we saw a clear benefit in Jallis, and makes me think that when I see subgroup analyses that it kind of raises more questions than it answers, and tells me that we probably need more trials.
Dr. Lee, will you be sharing your slides?
Yes.
Here we go.
Is it okay?
Yeah.
Yeah.
Looks good.
In this morning, I just presented speaker on title current concept in relation of hyperglyceridiums to ACE. So I just changed some slides for English. So I think the first thing is TG an independent risk factor for AS? If yes, how to manage it? So firstly, I would like to show the reasons for highly attention of TG recently. The first reason is ability of our ability to control LDL-C has been increased. The second is residual CV risk after LDL control. The finally is progress in understanding on TG and ACE. So recently, the omega fatty acid, whether this drug can reduce the cardiovascular risk, is distributed. The negative study showed the 10 meta-analysis showed the omega-3 fatty acid cannot reduce the cardiovascular events. This paper is published in JAMA Cardiology. Another negative study is stress study. In this study, they did not found the benefit from omega-3 fatty acid treatment can on cardiovascular events. The reason is many explanations, but I think I will give the reasons. Three negative studies is a many study. This study shows omega acid fatty acid cannot get a benefit from the omega fatty acid treatment from the older myocardial infarction patients. So only positive study is reduced study. So reduced study bring the happy for us because this study used the higher purely the IPE and high dose, high purified and also high risk patients. So this drug has been approved by FDA and European drug community. Why this omega-3 acid treatment cannot get similar results? In my opinion, I have some following the idea for this reason. The first is TG is a weak target for ACE. Not unlike LDLC. LDLC is more important than TG. The second is TG examination is not as homogeneous because the data is not TG examination can variation. The data can variation. The population, the result among population is homogeneous. This is the second. The three is OER fighting OER facial OER itself may or facial OER reduce the TG. The effect cannot distinctive description. So the fourth is OER compensation of the facial OER. The finally is control drugs or patient's status. For this reason, omega-3 fatty acid get a different result for cardiovascular inputs among different population and different studies. As we know, the fatty acid can cause your two kinds of the fatty acids. I cannot describe this conversation clearly, so I passed this slides. EPA or DHA, as papers reported, there is a different function on our humans organs. So this is maybe is a difference for drugs. Reduced study can get a positive result from the omega-3 fatty acid treatment because he used this study used a high purity fatty acid, also used the high dose, and this study also used the EPA pre-EPA production. So well, I think this 3 points is the key points for get a positive result from reduced study. So there is data computed these questions. The stress study used core OERs as a control drugs, and the reduced study used as a mirror OER as a control drugs. But I think mirror OER have no clear data gave this OER can impact, you have a better impact on cardiovascular system. So about the person's concentration of the EPA, DHA level concentrations on the study, there is also a study shows that if the person have a lower EPA, DPA, or DHA levels, he will get a benefit result from the omega-3 fatty acid treatment. But you go his higher level of these compounds, he can get the positive result. However, there is also a negative study, stress study show the EPA level concentration or EPA or DHA concentration does not impact, have an impact on the result. So that is the questions. Patients, the concentration of EPA or DHA concentration in patients based in the baseline at the baseline cannot have a same impact on the results. So well, I think more studying maybe is needed to discover the result why the omega-3 fatty acid get the different results. That's all. I'm sorry, I'm not well prepared this organization and the slides. Sorry.
No, wonderful job. Thank you so much, and a really important perspective. So KK, let me come back to you, having heard all of that, and kind of say, maybe, if there's a benefit, it looks like it's more with EPA than DHA.
Yes.
And we can debate whether there are differences in the trials according to the comparators that were used, and there were other differences in the trials in terms of the percentage of secondary prevention patients and the length of treatment and all of those types of things. It could simply be an icosapent benefit. It could actually be that it actually not only is about the EPA, but it's about the type of EPA. But we don't see overall a relationship here. What if we were to personalize therapy in the next trial and say that we were only going to give purified EPA to patients who had much lower levels, and that if you were already having an event, despite having relatively high levels of EPA, that maybe EPA wasn't the next treatment that you needed? Is that the next trial we need to do?
Okay, I maybe not fully understand your questions, but I can give my idea. In my opinion, in the future, we could design the more proceeding study on this question. We can use the same control drugs, such as oil, mineral core oil, or mineral oil, and also we can measure the EPA or the PHA the concentration in patients. Then select the patients for enter the study. Then follow up, look at the final result, why EPA or DHA had a different two. That is, we future should put more study to understanding the difference for EPA and DHA can get a different. In China, these drugs have maybe could on the market in this in the end of this year. So we also use these drugs to try to find to study the possible role of this drug on Chinese people with high TG levels patients.
Great. Okay, thank you so much for that. We might move on to the next talk, and then we can kind of come back to more of a discussion later. So I'm going to now introduce Dr. Adam Nelson from Melbourne, and Adam is going to talk about the ADAPTABLE trial.
Thanks, Steve. You see my screens okay? Great. Yeah, look, thanks, Steve. Really, real pleasure to speak this afternoon. And look, I think I've somewhat shoulder tapped for this one, having spent a couple of years with ECRI, but I can take no credit for any of the work that was done at ADAPTABLE. But it does show how a trial such as this does permeate a lot of what an institution does arrange, because ADAPTABLE did bring up weekly conversations with ECRI while I was there for the 2 years. But pleasure to present you on behalf of the APCMC. I have no disclosures for this talk. And I've reached out to Skylar, who is the principal investigator of ADAPTABLE, and he was kind enough to send me through his slides, and was pleased that we're presenting it locally in the Asia-Pac region. The background to ADAPTABLE really speaks to an interesting fork in the road from a pharmaceutical industry and a patent perspective, where aspirin was available at a dose of 81 milligrams and 325 milligrams, and the guidelines were relatively quiet on exactly what dose patients with established atherosclerotic cardiovascular disease should be treated with. And so whilst aspirin was universally recommended, the dose was not prescribed. This is in contradistinction to the APSC guidelines, which clearly suggest the dose of 100 milligrams is what should be administered. And the pharmacology is interesting because a dose of 100 ought to produce adequate inhibition of thromboxane A2, but that higher doses may indeed also inhibit prostaglandins and vasoconstriction. So there may be additive benefit, but there also may be additional risk around bleeding. And we know now that bleeding is tightly related to ischemic events in a complex direct and indirect way as far as the reduction of subsequent antithrombotic therapy or the need for cessation. The trial was originally founded on this data from the NCDR, where they looked at over 200,000 patients discharged from participating hospitals in the US and showed that over 60% of hospitals were sending patients with established disease on 325 milligrams of aspirin, and that there was considerable heterogeneity amongst institutions. And so then the trial was proposed to PCORI, and it was funded for $20 million. Interestingly, by the time they came to recruit, this number had dropped to around 25% of people being discharged on 325, probably because of the commensurate increase in more potent P2Y12 inhibition and possibly the increasing role or use of DOACs. Speaks to the challenges of running a trial that takes years to fund and then ultimately standard of care changes. So the bottom line of the trial was 81 milligrams or 325, the sweet spot for preventing ischemic events without causing undue bleeding. Two primary endpoints, the composite of all-cause mortality, hospitalization for MI, hospitalization for stroke, and a primary safety, importantly, was hospitalization for major bleeding that was associated with a blood product transfusion. And this speaks a little to the design around this trial, which being lauded for being pragmatic, meant that the endpoints collected needed to have been captured in relatively stringent and standardized data fields within the electronic health record and administrative claims data. So they were somewhat limited to what they could capture. Size of the trial originally was conceived at 20,000 patients. They had troubles recruiting, and so in 2017, the sample size was reevaluated and reduced to 15,000 patients. The additional length of follow-up meant that they were able to reduce the number of patients without a significant loss of power. This is the flow diagram. Patients were recruited in a fairly novel way, quite disruptive for the way in which we tend to pursue clinical research. There was a high-touch, traditional site outreach in person by investigators that recruited approximately 20% of the cohort, but then a really interesting low-touch, direct-to-consumer, direct-to-patient email or EHR-based message, or even traditional snail mail that resulted in 70% thereabouts of the cohort being recruited. The way in which patients then clicked onto via electronic means or were provided a link to then log on to and create a record within the patient portal available in English and Spanish. They watched an informational video, they followed comprehension questions about that, and they provided written informed consent via an electronic means. So this was quite a novel way to recruit patients. They were then randomized from that point in an open label way to over-the-counter 81 or 325. As I mentioned, the primary endpoint, both safety and efficacy, was ascertained in pragmatic means through administrative electronic health record data, as well as the use of the patient portal and phone follow-up. I'll spare some of the detail of the inclusion criteria other than to say they did try to enrich the cohort for events by looking at a number of factors, including the presence of diabetes, age over 65, or the presence of polyvascular disease. They really wanted to make this a very generalizable cohort, and so the exclusion criteria were minimal, remembering that patients themselves had to be able to identify these criteria, so they wanted to make it as simple as possible. This trial really fundamentally can call itself patient-centered, and for the first time, really in the US, they've managed to engage patients from go to woe in a very large trial. Patients were included in study design, they're included in consent, they're included in methods for recruitment, they assisted with patient onboarding, publicity. Interestingly, Mike Gibson interviewed one of the patients on the trial with Skylar at the ACC late breaking session. There really has been an attempt to bring patients into this, and they're also co-authors on a number of the secondary manuscripts. And we can see this permeating now to grant bodies today, where even salary-based funding is, there's a requirement to demonstrate how patients are going to be engaged in your research from go to woe. And I think this is sort of the poster child for how to do so. Data sources, as I mentioned, threefold: participant reported via either the portal or phone follow-up, the use of EH data, electronic health record data, or claims. And the non-fatal endpoints used a computable phenotype, not only to identify eligible patients initially, but then also to look for events in their linked data. PCORnet is a little foreign to Australians, but in Asia, there are certainly models of federated data systems. This is where you have a network of participating health systems that then contribute EHR. And what it allows is that you to be able to distribute a query within the health system and then to feed back data to one of these health networks in a non-identified way. So not only can you identify potentially eligible patients, but you can then capture data, and then it can be sent to a data coordinating center, trying to obviate some of the issues around privacy. So pretty neat for the US. This is a system that's been around since 2014, and ADAPTABLE was the first trial to do so. As I mentioned, 15,000 participants. They screened out 15,000 who did get to the portal, mainly the most common reason being a patient's unwillingness to change dose, having got that far, or that they had difficulty navigating the portal, or they thought the study was too burdensome. Ended up with 7,500 in each group. Fairly traditional cohort for secondary prevention, the mean age in the mid-60s. And the majority of patients, as I mentioned, were on the lower dose of aspirin of 81 milligrams, which was consistent with the data they had at study commencement, but not what study planning. And women occupied 30%, which is better than most, but still room to improve. Medical history is consistent again with established ASCVD cohort, with over half having had prior revasc and around a third having had a prior MI, and higher rates expectedly of hypertension and dyslipidemia. AF occupied only 8% of patients in this study, when we see that rates today, can be as high as 20 or 25% in older cohorts of patients. Relatively modest rates of self-reported bleeding. To the primary effectiveness endpoint at a median follow-up of around 30 months, there was no statistically significant difference in the rates of all-cause death, hospitalization for MI, hospitalization for stroke, with either the 81 or the 325 milligram dose. With regards to the primary safety endpoint, there was no significant difference in the 81 or the 325 milligram dose of aspirin. Draw your attention to here, the rates here of major bleeding being 0.6%, being perhaps slightly lower than what we would expect in clinical practice, speaks to two things. One is potential incomplete event ascertainment, and also the marker for bleeding here being a hospitalization requiring transfusion, which one would perhaps consider relatively aggressive or a significant bleed, where we perhaps may not be capturing all of the harm around perhaps more nuisance, but clinically significant bleeding. Draw your attention here to this in tabular form, all-cause death, slightly lower in the 81 milligram dose that did not quite meet statistical significance owing to the upper bound of the confidence interval crossing 1, but interesting signal in that respect. Non-fatal MI, no difference between the two. PCI and CABG, no difference between the two. Subgroup analyses here, as Professor Nicholls mentioned, ought to be evaluated with a degree of caution for a couple of reasons here, not only because, as I mentioned shortly, there's a significant amount of crossover between groups, and so the maintenance of randomization fidelity was low, but also because of non-significant primary endpoints. I will draw attention to the P2Y12 inhibitor use down the bottom there, that there looked to be a trend perhaps towards favouring of a higher dose of aspirin, although again, all of this is hypothesis generating. This is probably the most important slide to take home, and it challenges this notion of pragmatism around clinical trials, that just under a quarter overall switched doses within the study. This was open label. That was 41% for those randomized to 325, ended up on 81 milligrams. And interestingly, this occurred within the first 2 months. The most common reason for switching was participants' or physician decision in order to do so. And so one wonders whether those randomized to 325 then sought out their clinician who suggested that they should switch or be switched across. So suddenly when you have that degree of crossover, it's very hard then, even with an on-treatment analysis, to understand whether there were differences in efficacy. Median days of exposure here were consistent with the trial duration, but it does speak to challenges around how to interpret this afterwards. Even when you look at the sensitivity analyses, as I mentioned before, which ought to be interpreted with caution, really some suggestion around higher rates in the 81 milligram dose, but when you look at the degree of switch between groups, and a significant caution around interpreting what this means. I left Skylar's words here because the way in which this trial was presented was truly seen as a team-based effort. And so when he presented this, he said this was an army of people that were involved. It touched over 100,000 people from trial commencement to completion. The challenges around open label studies, again, were reiterated in this, whether you're pragmatic or not, that's a real challenge here. It was done in a real world environment. And whilst database lock occurred around COVID, COVID did have some contribution to it. The challenges that patients who were commenced on ticagrelor or beforehand were excluded, and patients who needed to have an anticoagulant upfront were also excluded. So we have some data-free areas there. Conclusions here are that really no observable difference on the data that was presented between the two doses. Significant problems around the switching of doses within the trial really make it hard to interpret this in clinical context. The messaging was critical, and PCORNet was big about this, that there needed to be dissemination at the trial level to patients. The patients actually were informed of the trial outcome before investigators were, which is kind of neat. Simultaneous publication in the New England. Look, I won't labour too much of this, but I did just want to perhaps touch on this challenge around pragmatic clinical trials and what, traditional or explanatory clinical trials. And again, this isn't meant to be didactic in any way, but I think this notion of being a pragmatic clinical trial as being a dichotomous variable is now being removed, in that it's rather than that, we see this elements of pragmatism. And so, whenever we look at a clinical trial, we need to understand the same sort of metrics of robustness and adherence to protocol are still required for us to understand and put the data in context. A garbage in, garbage out study makes it harder to interpret, even if it was done in a pragmatic way. This trial cost $20 million US, when a trial of this size for an explanatory or a regulatory grade study would be an order of magnitude higher, 200 million plus. These are some nice little ways to look at pragmatism in trials, and respecting the fact that as a much more pragmatic than most trial, with increasing numbers here suggests increasing pragmatism. So you would see something like ADAPTABLE being, somewhat circular, large circular, having a number of elements of pragmatism. Some of the challenges, pitfalls, and promises of these trials, you look at these sort of metrics. So 60% of patients had encounter completion rate, meaning that 40% of the cohort did not manage to complete their encounters during the trial. That sort of statistic at a regulatory grade study would be problematic. Randomization fidelity I've touched on already. You can see here in the light pink compared to red is the maintenance of the trial dose, and the blue is the degrees of missingness of data. So, real challenges here, that pragmatism means possibility, but it also challenges the sort of rubrics we look at measuring trials. Data sources I mentioned before is that none of them used an ECRF. This was all ascertained either direct from patient or via EHR and case mix. And endpoints, whilst it may seem in inverted commas easier for investigators to passively ascertain this is not straightforward. So the pragmatism really exists here for the patient rather than the investigator. So in short, some of the learnings I think we have here is that loss of randomization fidelity is a threat to any trial, whether you're pragmatic or explanatory or classical. The need for us to understand consistency and completeness of event ascertainment, which I think threatens the bleeding endpoint here. The challenges around low touch versus no touch. These patients were encouraged to attend the portal when there was phone follow-up. Maybe that's too little touch to be confident about event ascertainment. But we need to remember that these sorts of trials are important and are not going to be done by pharma. So we need to continue to look at bodies like the NIH, PCORI, for us in HMRC to run trials that are not based around remuneration. We look at the likes of Framingham, AllHat, CHS that have been fundamental ischemia more recently to our understanding. These sorts of trials we need to be able to do in a meaningful way, and it can't cost the earth. Patient-centeredness here we learnt from ADAPTABLE as possible, and they call themselves the adapters, with the patients involved, and seeing how that was done in a meaningful way, I think was empowering. And also the challenges here, the moving target of antithrombotics. We see now that more is not necessarily more. We're seeing now trials of shorter therapy, less potency, dropping aspirin, dropping clopidogrel. It's a really challenging space. And for a trial that ran for almost 6 years, you can see how just secular trends make it very difficult to end up with a concrete answer. So with that, I'll pause for any thoughts from the panel. Be interested to hear your thoughts, Steve, what your thoughts were, and KK from a local point of view, how this impacts Asian practice, if at all.
Thanks, Adam. That was great. KK?
Yeah, so I guess my thoughts run on both the results of the study as well as the pragmatic mechanism of this trial. I want to say that I doubt this would work in my country for now. There is still some degree of cynicism about participating in research trial. That's not to say we don't. It's just that it's for now high touch. A low touch mechanism is going to be rather challenging, both from a technology as well as a language standpoint. So I suspect that, as you pointed out, Adam, for say regulatory approval of a new drug, or new device, you will probably need a high touch trial, and such a pragmatic design may not work very well. As to whether it's 81 or 325, I don't think this trial, in my mind, is able to answer that question directly. If nothing else, it reassures us that 81 milligram is probably safe. And as you know, in Singapore, it's 100 milligrams. So I guess we're just going to stick to 100 milligrams for now.
Yeah, Adam. I agree. I think that I think the slide suggesting that it reassures people on lower doses of aspirin that's probably okay for most people. I guess one of the challenges with kind of these types of pragmatic studies, which is much more of a volunteer kind of approach to getting to them, is that you probably target a much lower risk cohort. I think you probably saw that in terms of both your event rate and your bleeding rate. I think our experience from the antiplatelet trials over the years is quite often the bleeding complications are more prevalently seen in the people who probably benefit the most from the agent. So risk kind of works kind of both ways there. And if you want to go out and do large pragmatic trials, I guess in the first generation of that, it is going to be lower risk kind of patients, and that might have an implication for the types of questions we might ask in those types of studies.
That's exactly right, Steve. I think that when looking at trial design, if there are ways that we could have done ADAPTABLE differently, was there a need for perhaps, was 325 an appropriate point of equipoise? To have 25% of patients by the time they started the trial, and for such a prompt change, there clearly must have been a degree of clinician insight or clinician inertia around whether that was a safe thing to be on. I think you're right. I think it speaks to understanding the question you're asking, being sure on the data that you're ascertaining. I mean, passive ascertainment of endpoints from a regulatory point of view, I think seems like a bridge too far at the moment. And as you know, coding type practices of such heterogeneity, within systems across countries, so I think fitness for purpose, I think, is another thing to think about here as well. This was the first trial Pecori's done nested within this system. We've seen taste in some of the Scandinavian countries. So it can be done in a meaningful way. It's a matter of understanding the limitations of, as you mentioned.
Yeah, I mean, I think one of the real strengths of this study is going to be the data set that's being generated. And I think that, if we're thinking about being pragmatic, then I think pragmatic comes to the types of analyses you do as well. I mean, the switching was highly prevalent, but it actually didn't reduce the number of days people were compliant or adherent with therapy. So I think there's a good opportunity here to look at exposure, concentrations of aspirin and those types of things. And I think, while you'll have a bunch of patients in the higher dose group who will have lower amounts of exposure because they underwent dose down titration, I think that will then enable for some really interesting analyses, which then might play into dosing ranges, which we more commonly see. I think most of us are used to using a more 100 milligram dose, as KK suggested. So it may be that it gives us a lot of information about that.
Yeah, absolutely.
Professor Lee, any thoughts? I think we might have lost him.
TG and TG.
Yep.
Yeah. In my opinion, TG and TG related drugs research have a long way to go, in my opinion, because the TG as a target is a relatively weak for developing coronary artery disease or the ASCVD. So we need more research to confirm this target is extremely important for AS development. So that is so we need more time and need to perform more study to confirm this finding. That is in my opinion. Okay.
Yeah, I mean, I think the triglyceride space, which you were kind of talking to, I think is important. And I think certainly up until now, we have no convincing data from any therapeutic that triglyceride lowering per se associates with clinical benefit. That was the case with the fibrates. It was the case in the Reduce It and the Jealous trial. So I think the jury is still out. I think what is potentially promising about triglycerides is the genetics. And the genetics do show that genetic mutations of factors that are associated with the metabolism of triglyceride-rich lipoproteins, such as APOC3, such as the angiopoietin-like proteins, do not only associate with changes in triglyceride level, but associate with changes in cardiovascular risk. And that would certainly suggest from a genetic perspective that factors associating with lipoprotein lipase activity, which is really the main factor that breaks down these triglyceride-rich lipoproteins, do appear to potentially play a causal role in the disease. So will the causal inference therefore mean that drugs that target those factors and therefore lower triglyceride levels, will they lower cardiovascular risk? We don't know. So what we do know is that there are multiple development programs currently underway, and we have a range of therapies. We have monoclonal antibodies, we have antisense therapy, we now have RNA interference therapy, which is starting to target these different factors. We've seen early studies show triglyceride lowering, Now what we need is for a number of those therapeutics to go into large-scale clinical trials and ask the question, will they lower cardiovascular risk? And I think if that's the case, then I think that would be the first legitimate evidence that we have that specifically lowering triglycerides is beneficial. What causes the potential benefit that we saw in the Reduce It and the JELIS study? It could be anti-inflammatory, it could be a range of other factors. So I think that the field is desperately waiting for a more triglyceride targeted approach. So we'll see that soon.
Steve, how do you uncouple the atrial fibrillation signal? I mean, as I remember reading, omega-3 supplementation was originally conceived, or at least early on, as a potential antiarrhythmic type drug. Certainly there was interest in it from a ventricular arrhythmia point of view. I mean, do you sort of see this as being biological or biologically plausible? Makes it, I guess we've seen it in 2 trials now, I guess.
So 2 trials starts to get concerning.
Yeah.
So interestingly, it's been the 2 trials that have administered the highest doses. And so, and you said, you're right, for a generation, we've thought that omega-3s may be anti-arrhythmic. We've done a bunch of trials that have tried to show that, do they reduce arrhythmia, particularly in a perioperative setting? They don't. And now you have an AF signal here, and you've seen it in 2 trials. So I think that we do need to understand it more. I think that as we continue to be confused about omega-3s and their health benefits, we know a lot of people take omega-3 supplements, and so then you start to think, are there potential kind of harmful signals? Given the fact that it's at higher doses, that reassures me that most of the supplements that are being taken by people in the community are relatively low dose. But I think we need some more work to understand what's going on there.
Steve, what about the earlier question I asked you regarding triglyceride levels and EPA? What are your thoughts?
I thought it was a great question, and so the short answer is we don't know. I guess one thing to keep in mind is that these are patients who are already on a statin, right? They're already on a statin. They've already had essentially a clinical event, or they're at a high risk of having a clinical event. And certainly in that cohort, we don't see a relationship. Would you see a relationship in people who are on no lipid modifying therapy across a much broader risk cohort? We don't know, but I think it's a great question and one that we can look at to some degree. But I think there are people who do metabolic studies where I think that would be really interesting to explore to a greater degree. And maybe to some degree it means that there may potentially be a ceiling effect. You may need a relatively low amount of EPA and or DHA administration to have an impact on lipoprotein lipase activity, and anything above and beyond that doesn't give you any more bang for your buck. So I think it tells us there's more work to do, where as sobering a thought as that is, after 30 years of omega-3 and fish oil studies, that we've still got some work to do. I think Reduce It is a really interesting observation. And I do agree with Dr. Bart and his assessment on that. I don't agree with him that it's the end of the story. So we've got some more work to do. Anyway, we've got to the end of our hour. I'd like to thank all of our panelists for joining us this afternoon, and importantly, thank you for joining us on a range of different kind of streaming platforms in this brave new world. We look forward to joining you throughout the year with some more webinars, and we thank both the Asia Pacific Society of Cardiology and the Asia Pacific Cardiometabolic Consortium for supporting this series. Enjoy the rest of your weekend.
Thank you. Bye-bye.
Bye.